So this is the draft that we try to put things together. And the first page, nothing much change apart from highlighting that we put the table of the comorbidities that actually associated with severe disease. So this table actually quoted from CDC, where shows a list of comorbidities that predict severe illness. On the left is supported by stronger evidence of meta-analysis or systematic review. The right side are other evidence like case control, cohort, retrospective case series. So strongest on the left side, as seen here, I think we all quite agree. Most of the comorbids are actually here. So actually the same, and in fact, it highlighted a few more that we should be aware of. Moving forward is warning signs, which was previously already there in the previous version. Put it into a table for a better overview by clinical, laboratory, and X-ray findings. So here is the specific treatment for our COVID. And this time, the table is divided in such where left side is category 1 until 5, and then followed by recommended with strongest evidence. In the middle, we'll have things we can consider, especially if it is available in your facilities, and remarks pertaining to the drugs that we are mentioning. So category 1, no treatment required. Category 2 and 3, we actually look at it as the same, right? So 2 and 3, the recommendations are the same, where supportive symptomatic therapy and always monitor for warning signs. So consider 2 drugs in these 2 categories. Still favipiravir within 7 days of illness and have any of the following risk factors: age 50 and above, plus comorbidity based on the table from CDC just now, or any of the warning sign presence. So highlighting that it should be within 7 days of illness. And the remarks are the same as previous version. Or if available, consider region cough, which is casirivimab, imdevimab. Pretty much the same. We are proposing within 7 days of illness. This is a monoclonal antibodies which should work on the early of the phase of viremic phase, and we try to address the population at the highest risk, where age 50 and above plus comorbidity pretty much the same as favipiravir. And the dose is only single dose. Either you can give it in intravenous or subcutaneous, and do not use in category 4 and 5 when patient already need oxygen. For remarks in category 2 and 3, steroids is not recommended unless we wanted to use it for other indications. And let me try to click. Just put one slide before we want to ask one poll questions to everyone, whether, because we are wondering, actually there are studies from Comet Eyes looking at sotrovimab. In the study design, they actually looking at within 5 days of illness. Region cough in their product, it mentioned within 10 days of illness. There's always this cost-effective design. You can give to everyone, but then in the end, we want to target the highest risk. So another consideration is our earlier 5,000 patients, 5,889 patients. We realized that if we extract out those with 50 and above with comorbids, within 7 days of illness, at category 2 and 3 on presentation, they contributed to the highest percentage of deterioration, which is 20%. So perhaps 7 days of illness can be of consideration, or even earlier of 5 days of illness. And this one I just want to highlight. Couldn't find much about 8 milligram, but if somebody tried to use 20 milligram, this is from the REACT from WHO. In critically ill patients, they are mostly mechanically ventilated. it is not significant when you use 20 milligram, but in recovery trial, 6 milligram makes a difference. Metoprolol, no difference with metoprolol 40 mg PD. So in obesity, if you look at the reference for DEXA in general, they say consider, if it's obese patient, consider using ideal body weight. And that means actually is look at the patient's height rather than actual weight. So another one in systematic review, if you adjust based on the body weight, may increase the initial plasma concentration after a loading dose, and this may not be appropriate. So overall lack of evidence of adjusting the steroid based on body weight. Okay, the last question is about metoprolol. So this thing I can't see. Okay, it's actually 2 milligram versus DEXA 6 per day. In the Iran study, they found that when used, metoprolol has greater clinical improvement, less ventilator requirements, and shorter hospital stay. Almost significant, we're showing a trend towards lower mortality, 19% versus 38%. And EJM Journal Watch commented this approach could be considered in patients with severe COVID. One of the few that things that may support metoprolol. Another one from US, retrospective study by a much larger number of patients using 1 milligram per kg per day versus DEXA or standard of care. They concluded that a sufficient dose metoprolol can lead to a further decrease in mortality as compared to DEXA. Okay. So if this is category 4B, when patient need the high flow mask or NIV, so recommended for metoprolol 2 milligram per kg per day. I think the same lah. We take out the or. So N remdesivir.
Not N or lah. N
only. And,
alone or N.
So I move on to last category. This one is just to say there's, I think, something newer, tofacitinib, also oral after 14 days, but I think it's more expensive than baricitinib. But again, they show some benefit in terms of mortality as well as respiratory failure at day 28.